So, in general, renal artery stenosis is a condition characterized by the narrowing of one or both renal arteries, which leads to reduced blood flow to the kidneys. It is a clinically significant cause of secondary hypertension, and it can lead to ischemic nephropathy if untreated. Understanding its pathophysiology is important, especially for understanding renal physiology, along with hypertension and vascular pathology. So, what are some causes or etiologies of renal artery stenosis? So the two main causes are atherosclerotic renal artery stenosis, which happens in about 90% of cases involving renal artery stenosis. It usually affects older individuals who are greater than 50 years old. It involves the proximal renal artery or ostium, and it is associated with generalized atherosclerosis involving the coronary, carotid, and the peripheral vessels. Another cause of renal artery stenosis is fibromuscular dysplasia. Now, fibromuscular dysplasia affects younger women ranging from 20 to 50 years old. Now, this time, it typically involves the distal 2/3 of the renal artery. And on imaging, you can see the string of beads appearance due to alternating stenosis and aneurysmal dilatations. So, here's just an image of a finding of renal artery stenosis for your reference. And so, in order to understand renal artery stenosis, we should review what normal renal blood flow looks like in the kidneys. So, kidneys receive generally about 20 to 25% of cardiac output, and then the renal blood flow is tightly autoregulated through the following mechanisms. Myogenic response, which involves the afferent arterial constriction and dilatation, and then tubuloglomerular feedback through the macula densa and the juxtaglomerular apparatus. Additionally, glomerular filtration depends on the pressure gradient between the afferent and the efferent arterioles. These factors impact the nature of renal blood flow in general. Okay, and then let's talk about the pathophysiology of renal artery stenosis. So, first we have some hemodynamic consequences to think about. Specifically, when the renal artery is narrowed, this is going to lead to decreased renal perfusion pressure. And the decreased renal perfusion pressure is going to activate the juxtaglomerular cells in the afferent arteriole. And the activation of the juxtaglomerular cells is going to trigger the secretion of renin. So there's going to be increased renin secretion. So this is where the renin-angiotensin-aldosterone system activation comes into play. Also known as the RAS system, by the way. Anyways, with the increase in renin secretion, you're going to have increased conversion of angiotensinogen to angiotensin 1, and then angiotensinogen is produced from the liver. Next, we have the angiotensin converting enzyme, or the ACE enzyme, converting the angiotensin 1 into angiotensin 2. And then the angiotensin 2 that is produced will be responsible for the following. The first one being vasoconstriction of the blood vessels, which means there's going to be increased systemic vascular resistance thereby increasing the blood pressure. There is also going to be the constriction of the efferent arteriole. And so, this will normally help to maintain glomerular filtration rate in hypoperfused kidney. Finally, the angiotensin II will stimulate aldosterone release from the adrenal cortex, and the released aldosterone will facilitate increased sodium and water reabsorption, and thus resulting in increased blood volume and blood pressure due to water following the sodium based on principles of osmolarity. So, with all of these activations, there's ultimately going to be systemic hypertension. This is because persistent renin-angiotensin-aldosterone system activation causes secondary hyperaldosteronism, where sodium retention and volume expansion prevails. So remember that sodium retention and volume expansion due to persistent RAS activation signifies secondary hyperaldosteronism. And then over time, this is going to contribute to resistant hypertension. And that is what can lead to renal artery stenosis. And so, just to remind you again, renal artery stenosis involves narrowed renal artery, which leads to decreased renal perfusion pressure, and that decreased perfusion pressure leads to activation of juxtaglomerular cells in the efferent arteriole, which then leads to renin secretion and ultimately increased blood pressure. Next, let's talk about the unilateral versus bilateral renal artery stenosis. So in unilateral renal artery stenosis, we have the affected kidney that is hypoperfused. This is going to lead to increase in your renin-angiotensin-aldosterone system activation, thus leading to systemic hypertension, as we explained earlier. On the other hand, we will have a contralateral kidney that is normal rather than hypoperfused. As a result of this, the normal kidney will be exposed to high perfusion pressure and is going to compensate this change by pressure natriuresis. So it does this by excreting more sodium to counteract the hypertension. This may lead to no volume overload initially, but the basic principle is that there's going to be natriuresis or excretion of sodium due to increased pressure or the increased perfusion pressure. On the other hand, bilateral renal artery stenosis, which can be equivalent to a renal artery stenosis in a solitary kidney. This is where both kidneys sense low perfusion, and so both of them are going to activate the renin-angiotensin-aldosterone system, which is then going to lead to marked renin-angiotensin-aldosterone system activation. There's not going to be any normal kidney to counteract this increased perfusion through natriuresis. This is going to lead to volume-dependent hypertension, and as a result, there's going to be high risk of flash pulmonary edema due to the volume overload and left ventricular diastolic dysfunction. So, the bottom line is bilateral renal artery stenosis, marked RAS activation, and volume-dependent hypertension. Unilateral RAS or renal artery stenosis, normal kidney is there to counteract high perfusion pressure through natriuresis. perfusion due to renal artery stenosis can lead to ischemic atrophy of the affected kidney. Ischemia simply refers to reduced flow of oxygen to the target site, and it's referring to the fact that a tissue can be vulnerable to damage due to lack of oxygen supply that would normally be carried in the blood. So, chronic hypoperfusion. What can this lead to? Tubular atrophy. It can also lead to interstitial fibrosis and glomerulosclerosis. Additionally, there can be a loss of nephron mass due to this renal ischemia, and this loss of nephron mass can lead to progressive chronic kidney disease, or CKD. So, what are some clinical features to watch out for? First, hypertension, especially resistant or early onset in young adults. We should also watch out for abdominal bruits whenever we can hear them, especially in cases of fibromuscular dysplasia. And then acute worsening of renal function after starting angiotensin converting enzyme inhibitors or angiotensin receptor blockers. This can happen in bilateral renal artery stenosis or stenosis in the presence of solitary kidney. And then, of course, watch out for flash pulmonary edema, especially in volume overloaded states. So once again, some clinical features to watch out for are hypertension, abdominal bruit, acute worsening of renal function after starting ACE inhibitors or ARBs, and flash pulmonary edema. For diagnosis, some important tests to conduct are Doppler ultrasound, because it is non-invasive, although it's operator dependent. This can help to see if there is some stenosis going on in the renal artery. You could also use a CTA or MRA, as they provide excellent imaging. But there's a risk of contrast nephropathy that can result from the use of this. You can also use captopril renogram or renogram, although it's less commonly used today, but still an interesting diagnostic tool. And then ultimately the gold standard test order to diagnose renal artery stenosis is called the renal artery angiography. Now keep in mind that this procedure is invasive and it should only be used in interventional settings. Once we have confirmed the diagnosis, of course we need to consider what treatment mechanisms to use. So, we can use some medical or pharmacological management. So, blood pressure control. They're normally controlled through ACE inhibitors or angiotensin receptor blockers. However, this can be problematic in patients with bilateral renal artery stenosis. So consider either use of diuretics, CCBs, or calcium channel blockers or beta blockers instead if blood pressure needs to be controlled, or specifically decreased. There can also be the use of statins to limit the production of cholesterol and ultimately the buildup of atherosclerotic plaques. You can also use antiplatelets and then counsel patients to stop smoking if they have a history of smoking. And then some interventional strategies include angioplasty and stenting, as they can be selectively used in acute renal artery stenosis. And then very rarely be reserved when there is some complex vascular anatomy going on or a failed endovascular treatment. And then last but not least, let's talk about why ACE inhibitors are significant in renal artery stenosis. So angiotensin II normally maintains a glomerular filtration rate by constricting the efferent arteriole. In renal artery stenosis, glomerular filtration rate is maintained primarily by this mechanism. So, what happens if you use an ACE inhibitor, which is responsible for preventing the production of angiotensin II? With the ACE inhibitors, you're going to have a dilation of the efferent arteriole because angiotensin II is no longer being produced. Rather, the ACE inhibitors are inhibiting the production of this. And so, dilation of efferent arteriole is going to lead to decreased intraglomerular pressure, which is then going to lead to acute fall in glomerular filtration rate. This can increase the risk of acute kidney injury, especially in cases involving bilateral renal artery stenosis or renal artery stenosis in a solitary functioning kidney. So, in summary, the features of unilateral and bilateral renal artery stenosis can be described as follows. There's going to be the renin-angiotensin-aldosterone system activation for both of them, although it will be more intense for the bilateral renal artery stenosis. There's little to no volume overload in unilateral renal artery stenosis, but the opposite happens in bilateral renal artery stenosis. Pressure natriuresis occurs in unilateral renal artery stenosis, but not in bilateral renal artery stenosis. There's risk with the use of ACE inhibitors, and that risk is mild in unilateral renal artery stenosis, but very high in bilateral renal artery stenosis, which could then lead to acute kidney injury. Flash pulmonary edema can typically occur in bilateral renal artery stenosis, but may be rare in unilateral RAS. And the best treatment options for unilateral RAS may involve medications or medication changes, plus or minus stent placement and FMD. And then for bilateral renal artery stenosis, medications can be used, but stenting should only be reserved in select cases. So FMD, remember that stands for fibromuscular dysplasia, which we talked about earlier. And yep. Alright, and lastly, here's a pretty helpful image about the use of non-steroidal anti-inflammatory drugs and ACE inhibitors and how they affect kidney function. So, non-steroidal anti-inflammatory drugs are harmful in that they affect prostaglandins. So, prostaglandins are generally the major determinant of afferent vasodilation. So, by inhibiting the prostaglandin production, the NSAIDs can cause the afferent arteriole to constrict, thereby reducing GFR. So we're going to have constriction of the afferent arteriole, which is going to decrease the flow of the blood to the glomerulus, thereby decreasing GFR. And remember that NSAIDs block the production of prostaglandins through this mechanism. And what happens if the patient is also on an ACE inhibitor? So remember that we said that ACE inhibitors are contraindicated in bilateral renal artery stenosis, as they are the major as angiotensin II is necessary for efferent vasoconstriction. The angiotensin II effect ASMR style lecture today. Alright, well, that is it for today's video. Let me know if you like more ASMR style